So imagine you're trying to treat like a severe structural leak in your house, right?
Okay.
And you do this by just handing the plumber a brand new rule book, giving them a firm handshake, and, I don't know, wishing them luck.
Yeah, that's a terrible strategy.
Right. It sounds completely absurd. You wouldn't expect the pipes to just magically fix themselves simply because the plumber, understands the theoretical physics of water pressure.
No, of course not. You need the tools.
Exactly.
Yeah.
Yet, for literally millions of low-income patients who are out there battling life-threatening high blood pressure, our modern medical system operates on that exact same logic. I mean, we hand out a diagnosis, we write a quick prescription, and then when the patient returns, say, 6 months later with their blood pressure still dangerously high, we act all surprised.
We do. We assume the patient just, well, isn't trying hard enough.
Yeah. But what if the problem isn't the patient at all? What if patient noncompliance is actually just a symptom of terrible system design?
And that is the crucial paradigm shift we are exploring today. We are looking at a landmark study titled Multifaceted Team-Based Strategies for Equitable Hypertension Control.
It's a bit of a mouthful, but it's important.
It really is. The focus here is uncontrolled hypertension. That's a condition where a person's blood pressure remains dangerously high despite, attempts at standard medical treatment.
Right.
And while this condition is a massive issue globally for everyone, it behaves kind of like an opportunistic predator. It disproportionately impacts populations who are already navigating severe socioeconomic disparities.
Which makes sense, sadly.
Yeah, so the mission of our analysis today is to find out if a really comprehensive, team-based approach can actually move the needle on blood pressure for low-income patients, especially when you compare it to the standard hands-off medical response.
Okay, let's unpack this. Why do we even need a totally new strategy for hypertension in the first place? I mean, don't we already have established clinical guidelines for doctors to follow? Hasn't the medical community figured out the basic mechanics of treating high blood pressure by now?
Oh, absolutely. The clinical guidelines definitely exist. And from a purely, physiological standpoint, we know exactly which medications dilate blood vessels and which ones reduce fluid volume.
So the science is settled, basically.
The chemistry is settled, yes. But having a map doesn't mean you know how to navigate the terrain.
Ah, I like that.
Thanks. The background of the study highlights this glaring disconnect in modern healthcare. The real-world application of those established guidelines frequently just fails the most vulnerable patients. We simply do not have robust data on the effectiveness of team-based strategies implemented specifically for low-income patients. Yeah, the medical establishment has the standard rules, but they lack the operational blueprint for making those rules actually work for populations trapped in the most severe health disparities.
Yeah. Man, that really forces the question, what does it actually take to cut through that socioeconomic static? Because, well, before we can even begin to analyze the actual treatment these researchers deployed, we first have to understand exactly who these patients are.
Right.
Because I really believe you cannot solve a systemic health issue without intimately understanding the specific population experiencing the disparity.
What's fascinating here is how the researchers designed the inclusion criteria. They actively sought out the exact demographics that traditional medical trials typically just ignore.
Which is huge.
It's massive. This trial randomized 36 federally qualified health center clinics across Louisiana and Mississippi.
And for those listening who might not be familiar with that term, a federally qualified health center, or an FQHC, operates on the absolute front lines of the American healthcare safety net, right?
Exactly. These clinics are located in medically underserved areas, and they provide care regardless of a patient's ability to pay.
So the researchers are intentionally stepping away from the wealthy, well-resourced academic hospitals and going straight into the trenches of community healthcare.
Right into the trenches. And they enrolled a total of 12,272 patients.
Wow, that's a solid sample size.
It is. All of them were 40 years of age or older, and crucially, all of them had uncontrolled hypertension.
So right out of the gate, we are dealing with a group where the standard approach, that standard map you mentioned earlier, has already completely failed.
Precisely. These individuals are living day in and day out with a chronic condition that places an immense invisible strain on their cardiovascular system. And the demographic breakdown of these 12,272 patients paints an incredibly vivid picture of the intersecting challenges they face.
Give me the numbers.
So the mean age was 58.8 years. The cohort was 56.7% women and 63.4% Black.
Okay, so older, predominantly female, and predominantly Black. But then you look at the socioeconomic reality of this group, and the numbers are just staggering.
They really, yeah.
Like 75.9% of these patients were unemployed. And 73.4% had a family income of less than $25,000 per year.
It's a totally different reality.
It's like trying to fix that leak in a house I talked about earlier. You can't just look in the pipe. You have to look at the whole environment.
Absolutely.
When almost 3/4 of your patients are surviving on less than $25,000 a year and dealing with unemployment, you aren't just fighting blood pressure, you're fighting an entire socioeconomic reality.
You're fighting a lot of upstream battles.
Exactly. You are
And-
fighting food deserts where fresh produce is a luxury. You are fighting the chronic cortisol spiking stress of housing insecurity. You're fighting transportation barriers that make a simple follow-up appointment feel like a massive logistical hurdle.
And that socioeconomic context changes the entire nature of the disease. In that environment, taking a daily pill or attending a midday clinic appointment becomes a monumental task. It's competing with basic survival.
Right, because if you're worried about making rent, the blood pressure pill might not be top of mind.
Exactly. By specifically targeting unemployed, low-income patients at these safety net clinics in Louisiana and Mississippi, the researchers gathered vital missing data. This study steps beyond testing a chemical compound in a vacuum. It tests a delivery mechanism in the real world.
Which is so rare.
It is, and that is a vital step toward actual health equity.
Because if you can prove that a strategy works in this highly stressed, profoundly under-resourced environment, you've essentially found a solution that can work anywhere.
That's the hope.
Which leads us directly into the blueprint of the care itself. We understand the immense daily pressures facing these patients. Now we really need to look at the two different clinical approaches the study tested.
Right, so they split the 36 clinics into two groups.
Let's look at the control group first. This group received what the study refers to as enhanced usual care. And I have to admit, seeing how basic this was really surprised me.
Yeah, the term enhanced usual care often sounds much more robust than it actually is.
Right, it sounds like they're getting extra features or something.
Exactly, but in this case, the intervention for the control group simply involved educating the physicians and clinic staff about the existing clinical guidelines for hypertension.
That's it. They essentially just handed the doctors a refresh manual on best practices, maybe ran a few seminars on the latest blood pressure targets, and then sent them back into the clinic.
That is the core of it, yeah. They basically ensured the providers were fully up to speed on the theoretical rules of hypertension management.
Man, that's wild. Okay, contrast that with the intervention group, which received a multifaceted implementation strategy.
Which is a whole different ballgame.
Totally. And this was not a theoretical manual. This was a heavy-duty, heavily structured approach that practically wrapped around the patient.
Right.
It included team-based care, meaning the doctor wasn't operating alone. It included protocol-based intensive blood pressure management. It involved blood pressure audits and feedback. They deployed health coaching aimed at lifestyle changes and medication adherence. And they equipped the patients with home blood pressure monitoring devices.
Wait, so the control group basically just got a refresher course on the rules, while the intervention group got an entire support system.
Yeah, that's the setup.
Isn't that like giving one person a manual on how to build a car and giving the other an entire pit crew?
If we connect this to the bigger picture, your pit crew analogy perfectly captures the systemic friction at play here. Standard medical care is like telling a driver to pull over, read a manual, and change their own tires while they are still in the middle of a race.
Right, and they're losing time.
The friction of daily survival makes it nearly impossible for these patients. The multifaceted strategy provides a pit crew. The patient simply pulls into the box, and a coordinated team removes the friction of managing the disease.
Which is beautiful in theory.
But we have to understand why the medical system defaults to the manual. Educating a physician requires minimal structural change. It is cheap, it is scalable, and it doesn't require hiring new staff. See, I have to play devil's advocate here, though. Building this pit crew, providing a team-based care model, dedicating staff to audit blood pressure data, paying for health coaches to call patients, and buying home monitoring equipment. That all sounds incredibly expensive.
It's definitely an upfront investment.
Right. So if I'm a hospital administrator or a policymaker, I'm looking at this multifaceted strategy and seeing a massive ongoing drain on resources. Does the data actually justify that kind of systemic overhaul? Or is this just an idealistic wish list that clinics really can't afford?
Well, that skepticism is exactly why this trial is so important. To convince the medical establishment and insurance providers to invest in the pit crew, you cannot rely on the argument that it just, feels like better care.
Feelings don't get funding.
Exactly. You need undeniable, rigorous data proving that the extra resources yield drastically better, quantifiable results than the status quo. You have to demonstrate the return on investment in human health.
And to demonstrate that, we really have to look closely at the mechanisms of how this pit crew actually functioned. Because they didn't just throw resources at the wall and hope something stuck.
No, it was very targeted.
Take the blood pressure audit and feedback, for example. Instead of waiting for a patient to schedule an appointment 6 months down the line, the clinic team actively reviewed their entire patient panel's data. They identified whose blood pressure was creeping up and proactively reached out.
And that proactive shift is monumental. It completely removes the burden of initiation from the patient.
Yeah, takes it off their plate.
Right. And pair that with the home blood pressure monitoring. White coat syndrome, where a patient's blood pressure spikes simply because they are anxious about being in a medical setting, is incredibly common.
Oh yeah, I get that myself sometimes.
Many people do. So by equipping patients to take their own readings in the safety of their homes, the clinical team gets a much more accurate picture of their baseline physiological state.
It also gives the patient immediate, tangible feedback on their own body. Like they can see the numbers change based on their choices.
Exactly.
Then you add the health coaching. For a patient surviving on less than $25,000 a year, a doctor saying eat less sodium is practically useless advice if the patient relies on canned goods from a local food pantry.
Because canned goods are usually loaded with sodium to preserve them.
Right. But a health coach can actually sit down and figure out realistic, achievable dietary substitutions based on the specific store or pantry where that patient actually shops. They're bridging the gap between clinical theory and daily reality.
So the question becomes, did bridging that gap actually work over the 18-month trial period?
Well, let's dive into the results and measure the impact of the pit crew. The primary effectiveness outcome was the mean change in systolic blood pressure from baseline to 18 months.
And for anyone listening who gets those two numbers on their reading confused, the systolic pressure is the top number.
The one that's usually higher, right?
Yes, the higher one. It measures the actual physical force your blood is exerting against your artery walls every single time your heart beats.
Which sounds intense when you put it like that.
It is. When that number is chronically high, it is essentially hammering the delicate lining of your blood vessels, creating micro tears that lead to plaque buildup, strokes, and heart attacks. So lowering that top number is the primary goal of hypertension management.
Okay, so at the 18-month mark, the intervention group, the patients who received the team-based care and home monitoring, saw a mean drop in their systolic blood pressure of negative 15.5 millimeters of mercury.
That is a very significant drop. Now, compare that to the control group, the enhanced usual care group.
The ones with the educated doctors.
Right. Their physicians had been freshly educated on the guidelines, and as a result, those patients also saw a drop, but their mean reduction was only negative 9.1 millimeters of mercury.
Which means we're looking at a between-group difference of negative 6.4 millimeters of mercury in favor of the intervention.
Yes.
The pit crew resulted in a significantly greater reduction in that dangerous physical pressure.
Statistically, with a p-value of less than 0.001, this is a highly significant finding. The intervention clearly drove a deeper, more profound reduction in blood pressure.
But the researchers didn't stop at just the blood pressure cuff, did they?
No, they didn't.
They also measured a primary implementation outcome, which they call the adherence summary score. And this was measured on a scale of 0 to 4, with higher scores indicating better adherence to the management protocols.
Right, and this isn't just about whether they swallowed a pill.
Exactly. It tracked whether they were showing up to appointments, engaging with lifestyle modifications, and actively participating in their care plan.
Over the 18-month follow-up period, the intervention group had a mean adherence summary score of 2.8. The control group, relying on standard care, scored 2.1.
That is a 0.7-point difference on a 4-point scale. Which, I mean, it sounds like a small fraction, but over a year and a half, that indicates the intervention group was far more consistent in navigating the complexities of their disease.
The coaching and the feedback loop really kept them engaged.
Here's where it gets really interesting, though. When I first looked at the design of the intervention group, my immediate thought was about the potential negative side effects of throwing all this extra medical infrastructure at these patients.
Oh, like overwhelming them.
Yeah. You are taking individuals who are already dealing with massive socioeconomic stress, and suddenly you are introducing intensive medication protocols, home monitoring devices, regular coaching calls. It seems highly likely that this could just overwhelm the patients or even lead to medication complications from aggressively lowering their blood pressure so fast.
It is a very valid concern. Aggressive blood pressure management can sometimes lead to dizziness, fainting, or acute kidney issues if the patient isn't closely monitored. The trial rigorously tracked these serious adverse events across both groups, to be sure.
And the data showed that serious adverse events occurred in 20.9% of the patients in the intervention group. In the control group, the patients receiving just standard hands-off care, the rate of serious adverse events was 21.7%.
Wow.
They're practically identical.
Well,
The heavy-duty, multifaceted strategy was just as safe as standard care, but vastly more effective.
this raises an important question for you, the listener, as you evaluate how we design healthcare systems. What does a negative 6.4 difference in systolic blood pressure and a zero point 0.7 increase in adherence actually mean in the real world?
Yeah, beyond the spreadsheet.
Exactly. In the realm of cardiovascular health, these seemingly small numerical differences represent a seismic shift in a patient's risk profile. Dialing down the physical stress on a person's vascular system by an additional 6.4 points dramatically reduces their immediate risk of suffering a catastrophic stroke or a heart attack.
It's life-saving.
It is. It proves that the intervention's success isn't just a statistical blip on a spreadsheet, it is a profound clinical victory. It shows that providing a multi-layered support system doesn't overwhelm the patient. It absorbs the friction of their daily life so the treatment can finally work the way it was originally intended.
By distributing the effort across a dedicated team, the system finally takes on the heavy lifting. It stops expecting someone surviving on less than $25,000 a year to magically overcome the structural barriers of poverty just because a doctor handed them a pamphlet.
The overarching conclusion drawn by the researchers is unequivocal. Among low-income patients battling uncontrolled hypertension, a multifaceted, team-based implementation strategy results in a significantly greater reduction in systolic blood pressure and far better adherence than simply educating doctors on the latest guidelines.
So what does this all mean? We started out by asking if we needed a totally new strategy to tackle health disparities, and the data from this study delivers a resounding yes.
A very loud yes.
It means that patient noncompliance is frequently just a failure of the care model itself. For our most vulnerable populations, the traditional medical transaction, the diagnosis, the prescription, the manual, is a fundamentally broken equation.
This study serves as a powerful reminder that clinical knowledge is only valuable when the system is designed to apply it effectively. We have understood the chemistry of hypertension for decades.
Right.
What this trial provides is the operational blueprint for how clinics can deploy that knowledge equitably. It proves that when we design care systems that actively compensate for a patient's socioeconomic reality, we can actually begin to close the gaps in health disparities.
It is incredible what happens when you stop lecturing the patient and start supporting the whole environment they live in. Which leaves us with one final thought for you to take away today. If a multifaceted strategy, giving patients their own PIC crew with proactive audits, home monitoring, and dedicated health coaching, can create such a dramatic improvement for uncontrolled hypertension in our most under-resourced clinics, wait, what other chronic, everyday conditions could be entirely transformed if we stopped just handing doctors rule books and started giving patients a team?